Hey everyone, this is Fareed Riaz. Welcome again to tonight's SIR Resident Fellow Section webinar. Um, and as everyone who's here right now probably knows, we hold these sessions about every 2 weeks or so. So thank you all for showing up tonight. Just one housekeeping tip: if you've got any questions during the time when the speaker's talking, go ahead and type them into the question box, and we will hold all of those at the end and ask them all at the end. But you should feel comfortable going ahead and asking those, typing them in when you think of them, so they're kind of queued up. All right. And then it's my pleasure to introduce Natasha Monfort. She is part of the Women in IR section of the SIR Resident Fellow section. So she'll be introducing our speaker tonight. So Natasha, the floor is yours.
Thank you, Fareed. My name is Natasha. I am an R2 at the University of Oklahoma, and I have the honor of working with Dr. Keri Conner. She is awesome. She did her medical school at the Oklahoma State University School of Osteopathic Medicine, and she completed her residency at Oklahoma State University in Tulsa. She then did her fellowship at Baptist Cardiac and Vascular Institute in Miami. She has been a practicing attending for about 5 years now, and she is currently the chief of our vascular and interventional radiology department. And she is going to be giving us a talk on practical approaches to radiation safety. So here she is, Dr. Conner.
Thanks, Natasha, and thanks, Fareed, for the introduction. Tonight, we're going to talk about some practical approaches to radiation safety. And I know that sounds really boring, but this is really basically about just starting good habits. What I really want you to get out of that, and what I want your objective to be, is to acquire habits both to decrease operator and staff dose, as well as to decrease your patient dose in addition to yourself and your staff. So one of the things you should be familiar with, and you guys have probably heard of ALARA, but this is, it stands for as low as reasonably achievable. And it's a really good goal to have, because this balances both the patient safety or the clinical procedure success without, you having too much radiation risk to yourself or to your staff. And it is common sense, but it's also a regulatory requirement. And the Image Gently website is a very good resource for you, both in pediatrics and adult. It also has many resources not only for interventional radiology, but also for CT and other radiation sources. So why is this so important? I think the picture on the left speaks for itself. Obviously, this was probably a cardiology catheter-based coronary angiogram, but the same picture holds true for any kind of highly complex procedure. We don't want to see this ever happen to us, and if it does happen, you need to know why it happened, how to prevent it, and if it did happen, what you do next. And in addition to the danger exposed to the patient, you also are exposing yourself to radiation risk throughout your career. So if you start good habits now, then you can decrease the risk and the likelihood that you might have a cataract or some sort of other unfortunate thing happen. So keep in mind that one difficult tip can be almost equivalent to 3,000 chest x-rays. So that's an extremely exorbitant number of chest x-rays that you would do to one patient. And in one procedure, you could be doing this both to the patient and to yourself. So it's good to know what your deterministic effects are and what the numbers are that you can kind of be in a safe range, but then when do you start getting worried? So it really takes a lot of absorbed dose to really get to a point where you really have irreparable defects, such as the one we saw in the previous picture. So if you're less than 2 gray, you can pretty much be in the clear, that you know that you're not going to have any visible skin injuries. And then once you get into the 3 to 4 gray range, you might see some skin epilation after 2 to 3 weeks. Now, even in the 3 to 4 range, you'll hardly ever see it. Really, when you start to see any kind of skin changes is when you get into the 10 to 15 gray range, and this is the threshold for erythema. It really does take quite a complex procedure to start to get in the 10 to 15 gray range, but I have done it multiple times, and I always kind of keep in mind the things we're going to talk about tonight to make sure that, if I talk to the patient, go, this could be something we'll need to see you back in a couple of weeks, or if there are things that make me feel more comfortable, then I don't have to worry about it, and I really don't need to worry the patient over much. Now, if you start getting in the 20 to 25 and above that gray range, you're really doing something wrong. I mean, that'd be a very, very aberrant amount of radiation. But when this does come into play is when you start having multiple cases of the same patient in multiple days. Let's say you bring the patient back for a declot, and then you do another case the next day. When you start thinking about additive effects, even though these are deterministic effects of a single setting, you need to keep in mind that if you're doing a bunch of procedures within a very short period of time, that these numbers can add up. So, don't think that you're just back to zero. Now, fundamental methods of radiation protection apply almost always for both you and the patient. What's good for you and is good for the patient, and what's good for the patient is good for you. That's not always true, but generally speaking, you can follow that rule. The most important thing you can do is to decrease your time. So we start talking about time, distance, and shielding. If you have your foot off the pedal, everything else is zero from that point on. If you do have to put your foot on the pedal, then you need to start thinking about distance, increasing your distance from the X-ray source. And if you can't increase your distance, then shield something between you and the source. So once you are getting ready to do a procedure, before you're entering the room, you need to know what it is that you can do decrease exposure before you even put your foot on the pedal. So make sure you wear body lead, make sure you wear a thyroid shield, make sure you wear glasses. This is an investment. Hopefully your practice will buy these for you. We'll talk about some of the options as far as side protection and things like this. And then gloves is an option. So body lead, generally everybody wears it. A lot of people will buy two-piece if you're in lead all the time, you'll see people wearing single pieces, but that's just a preference. You want to wear the thyroid shield. The 0.5 millimeter lead equivalent is typically required as a federal regulation. Now, the reason I bring that up is because you can actually buy lead that's less a lead equivalent than this. So even though it's on the market, it may not be something that meets requirements. So just be careful with that. And then also the back may not be fully or even lead lined at all. So if you turn your back, if you're the first assist and you're looking at the prep table and you're helping with catheters and things and the radiation source is active, then you will be exposed completely if you don't have a lead lined back. So eye protection, when I first started out, I had glasses like we see on the left. Of course, they're prettier, they look better, but my friendly radiation physicist came and said, you're not getting any protection from the sides. And as we all know, most of the cases we're actually standing tangential to the patient so that your face is actually in profile somewhat to the patient. So consider when you buy lead glasses that you may look at buying something with side protection. Not as pretty, it's not as sexy, but it will save you radiation exposure to your eyes. And then why do we want to do this? Remember, this isn't sexy right here. So eye protection, you're going to talk about studies that suggest excess incidence of radiation-induced cataracts. So we don't know, there's no linear relationship, but we do know that there is an incidence that relates to cataracts. So what you will do is have 0.75 millimeter lead equivalent glasses, and that can decrease your factors by 5 to 10. Then if you introduce a scatter shielding drape in between you and the radiation source, then you're also decreasing that factor by 25. So then if you're using both glasses and a drape, you can decrease your lens dose factor by at least a factor of 25 or even possibly more. So now we're going to go on to gloves. Now, I say buyer beware not because they're a good thing, but used in the hands of someone who's not really knowledgeable about lead gloves, it can actually be bad for you and bad for your radiation exposure. So before you think that it's an innocent thing you put on your hands and it really saves you, you need to know the pros and the cons before you invest in these. So why? The question is really to lead or not to lead with the glove. So avoid positioning one's hands within the primary beam is recommended, and it's paramount when you're wearing leaded gloves or over wearing leaded gloves. And the reason for that is leaded gloves can actually cause the ABC, the automatic brightness control, to deliver a higher dose because it thinks it's something it needs to get through. So it's trying to penetrate your gloves. So if your hands are in the field, you're actually making yourself have higher radiation exposure because the gloves can be penetrated, and then they additionally add more forward scatter and back scatter, contributing more to your operator dose. So if you do decide to use gloves, they should only be used if your hands are near, but not in the primary beam field. So when would you use gloves then? So if you're doing a lot of procedures where you're really close to the radiation field with the primary beam, such as a lot of dialysis procedures, you're kind of hugging the II, then, as long as your hands aren't in the field, then you can talk about using leaded gloves. If you see your hands in the field, you should probably not be wearing leaded gloves. So that's just kind of a good rule of thumb, that you really shouldn't have your hands in the field. And if you have leaded gloves in the field, then you're just hurting yourself more than you're helping yourself. So now we've talked about our lead, we've talked about personal lead and thyroid shields and gloves and glasses. So now we're going to go into the room, we're getting ready to scrub in, but we need to take stock of what other things we can do to kind of help us decrease our radiation exposure. So depending on where you practice, you may have a variety of table shields and table drapes. And you may even be involved in the buying of these in the future. So there's fixed and mobile shields. Mobile shields are not only for you, but you should think about that for your nurses, for your support staff, and even for anesthesia. You can take stock of where your lead shields are. Are they on your machine? Sometimes they may not be, attached. They're removable, so you may want to put them on the machine. And there's also upper body and overhead shields. A lot of the ceiling-mounted units will often have a mobile hanging shield that almost every angio equipment has. So here's a great example of one of our residents that he's scrubbed in, he's ready to go, and he's ready to start. We're going to take a look at this. Is he ready to go? Is this optimal? So it looks good from here, but let's break it down. So the first thing, we have mobile lead and mobile drapes. So even if you don't use the mobile lead, and a lot of people don't, you should at least consider it for your first assist. They may want to have something in between them since they're not going to have their hands in the field. But if you're doing something where your hands are near or in the field at all times, or you're having to kind of touch the patient quite a bit, let's say you're doing a PTC and your hands are mid-axillary, then you may not want that. But give the first assist the option. Over to our right is a tall plexiglass shield that we use for our nurses. That way, if a nurse has been sitting for a while and they've got the option of taking off their lead aprons. Also, we use this for anesthesia quite regularly. So shield variety. We're going to talk about leg shields. These are almost certainly going to be on your machine. Ours can be taken off, but this picture is a great picture to show that the leg shield is protecting the radiation source where the blue arrow is going to. This also shows where the patient would be, and it shows you a gap between the table itself and where the top of the leg shield is. So this is a very important space to note. So both the leg shield protects you from both backscatter as well as the radiation source. So your hanging shields are going to protect you from forward scatter. So if you look at this patient in the first picture, any scatter that's coming off of the patient is going to hit that shield first before it goes anywhere close to you. So these are very effective in combination with your lead aprons that you wear. Bridging shields are used to kind of complement the distance between the leg shield and the hanging shield. These vary by vendor and can be removed. Ours actually has those two little hooks there on each side, and it just comes right off. It's very easy to remove, and it's very easy to put on. Even if the patient is draped, we can take it off and on very easily. This is more useful for angio cases. If you're not going to be close to the abdomen of the patient, then this won't get in your way as much if you're doing a femoral puncture and you're down the table. If you're doing a PTC or something like that, this might be more difficult and maybe in your way, but it's useful to consider for many angio cases. So when we combine the shields, on the far left, this is kind of your basic, okay, I've got my leg shield, and that's what a lot of people use. But if you do have a bridging shield, that's even better. That kind of closes that gap between the patient and that little 3 to 5 inch gap between the leg shield and the patient's table. And then on top of that, if you move along, you can even add the hanging shield. Even if you're not using it the entire case, if you're using it even a portion of the time, you're just going to save yourself that much exposure. And, you know, if you have an additional hanging shield to the far right, you know, even for maybe your first assist or if someone's watching you or something, you can just add that much more safety and precaution for both you and the patient. So now we can go back to our good resident that's getting ready to start, and we can break down what he's done here. He's done a very good job. We've built in every kind of protection we can for him before he even punctures the femoral artery. So you see the large plexiglass lead to his left, and that is right just inside of where the lateral, this is a biplane, so you see it's just in front of the lateral plane, and it's also in front of the frontal plane, so that's protecting him from the get-go. Then you move down, he's got a hanging shield to bridge that gap. Then he's got a bridging shield to bridge the gap between his leg shield and to protect him from scatter from the patient's body. And then he's got the leg shield. So he's got 1, 2, 3, 4 shields built in. Now we look at what he personally has on. He has lead glasses with side protection, great. Thyroid shield, yes. Lead vest, yes. Lead skirt, yes. And he's chosen not to wear lead gloves. So he's scrubbed in, he's ready to start his case. What is he going to do next? So the first function that you need to really concentrate on is really getting your foot off the pedal. Especially in your early career, you're going to want to see everything and things are going to take longer, so you're going to be fluoroing much more. And as you get become more practiced and more experienced, you're not going to need as much fluoro time, but it really behooves you to try to stay off the pedal as much as possible and to even intermittently fluoro, even if it doesn't really mean anything to get off the fluoro, just to get in that habit. Most machines have a last image hold capacity, so you can use that last image hold, and that's 0 radiation. You can just say, okay, where was I? Oh, that's where I was. Reposition the patient without fluoro or with minimal intermittent fluoro. If you're moving the patient, you really don't need to be fluoroing. You don't need to see where you're going. You can always fluoro once you've got the patient into a moved position. And then you can also question, for this part of the procedure, if I'm exchanging a catheter, you know, if I'm doing Seldinger technique, you don't necessarily need to fluoro. I mean, if the wire is really not moving or you're not doing anything that could be of risk to the patient, then you don't necessarily need to fluoro, and you should question it if you should do so. The next thing that can dramatically decrease your radiation exposure is physical distance. If you have to fluoro, then the next thing you can do to make yourself safe is to increase your distance. And the reason this part is so important is radiation can reduce by 1 over the distance squared. That means every time you double the distance from where you stand, you've decreased your radiation exposure by a factor of 4. So that has decreased your exposure by a factor of 4 if you just move 1 foot. So keep that in mind. Anything that can buy you a couple of inches, 6 inches, a foot, or even a foot or 2, that's just going to decrease your radiation by so much. And that's why a lot of people feel that once they're about 5 feet out, they're really basically to 0. So examples of this would be choosing longer catheters. I'm going to go back to our good resident here, and if you look at his long catheters here, this is probably a neuro case because of the catheter they've chosen, but you can still say that he's going to be in this area before he even puts a microcatheter in. So you could potentially use a longer microcatheter, and we have multiple lengths of microcatheters, 110 centimeters versus 130. So if you have a medium-sized patient and you use a microcatheter that's 20 centimeters longer, you've just bought yourself 20 centimeters more distance. So put that 20 centimeters into your distance calculation, and you've decreased your radiation exposure by 4. Additionally, you can move the monitors down, you can bring the pedals down, anything you can to just buy yourself a few more inches. Now, it's very paramount when you're doing DSA runs, especially if they're automated, you don't need to be in the room. And you should also make sure that anesthesia and your nurses are as far away from the patient as possible during the DSA run. So position, you know, we don't have robotic interventional radiology. You have to be near the patient. So all of us in the lab, including nurses and staff, are going to be unavoidably irradiated during these duties. So until that time, we have to ask ourselves, what can we do to decrease our radiation exposure? So we can use examples like the lead glasses, the shielding, and better technique. Remember your staff. The same rules apply to everyone that's in the room, especially your first assist and your nurses, everyone that's around. Especially be aware if you have pregnant staff. It heightened my awareness of radiation exposure and having a pregnant nurse, and you'll never be as nervous as you are when you have a pregnant nurse about 6 feet away. Anesthesia, which are very over-comfortable because they're used to being in the OR with a C-arm, and they may or not even want to wear lead. But they need to realize, and you need to realize, because you're the responsible captain of the ship, so to speak, that they are on the opposite side of the radiation source that does not have a leg shield. So what we do is we put the large plexiglass in front of them and let them sit behind that. And we usually ask them, even though you're behind that, please at least wear minimal lead. And I think that's a reasonable, thing to expect from them. Respiratory therapy students, residents from other services, they generally have no experience with radiation, especially the kind of radiation that happens in the interventional lab. Again, they may only be used to, the OR where it's a C-arm, and the people that are 3 feet away may not even be wearing lead at all, much less implementing other radiation safety precautions. Now, one thing I have learned just in the last couple of years is you need to be aware of where your nurse is. I mean, we're doing our own thing, and we're really not paying attention to what's happening with the nurse. So this is a great picture of so we're over there concentrating, we're doing our job, trying to do a great job of the procedure, and the nurse, her job or his job is to check on the patient. And they have to get close to these patients. Usually it's with moderate sedation. They may not be able to hear because a a drape is in the way. So this is what's typically happening. The nurse is peeking under the drape saying, hey, how are you doing? And we're over there hitting the pedal at the same time. So the patient's there, and then the nurse's nose is right under the IR or the detector, the II or the detector. So be really careful. The nurses are going to have to check on the patients, one, to make sure that they're reasonably safe during moderate sedation, but the patient's nose is going to itch. They're going to have to scratch the patient's nose. They're going to have to adjust the nasal cannula. So just be very aware of where the nurse is, or at least ask the nurse, hey, when you're going to check on the nurse, kind of let me know that you're getting close to the II. So during the procedure, we're going to do a number of things that relate to physics. And the scope of this talk is not to talk about physics, it's really to talk about the practical applications of the physics in the cath lab. So when we've talked about it, we need to beat it into our memories. Limit your fluoro time. So the first thing we're going to do is employ good collimation. And we're going to collimate with fluoro off. We don't need to collimate with a fluoro on. A lot of machines will actually show you where you're collimating with a fluoro off. We're going to employ fluoro time alerts. And you might even consider exposure alerts, because fluoro time is not a great measurement of fluoro exposure. And so if you have exposure alerts, that's a great thing to implement. In our lab, we consider exposure alerts at 1.5 gray, because our minimal limit is 2 gray. And then every 500 milligray after that, the tech alerts us, okay, 500 milligray, 500 milligray. And then they give us a cumulative, okay, you're at 3 gray, you're at 3.5 gray. And we really don't consider fluoro time that much. Last image hold, again, that's going to show you your last image. We're going to talk about minimizing your air gap, and we're going to show you some pictures of what that means and why that's so important. We're going to talk about limiting magnified fluoro. We're going to talk about decreasing pulse fluoro, and we're going to talk about decreasing your exposure setting. Now, these last 3 things are the things that you're really going to not want to do, because all 3 of these last things make your images pretty. So just remember that anything that makes your image pretty is going to increase your radiation exposure. So it's going to be counterintuitive. You're really not going to want to do it, but you need to get into the habit of going back to what is a LARA about. It's as low as reasonably achievable. So what is the most reasonably achievable and decreased exposure rate that you can use and still get the procedure done and maintain a safe atmosphere for the patient? So when we talk about fluoro equipment controls, our field of view, our ghost rate modes, pulse modes, and last image hold are things that you kind of do in the room and that generally increase exposure, except for last image hold. Collimation is the thing where you can kind of pare down your image, and I'll show you a picture here in a second. But it basically is that you're showing only the necessary image area. You can enable your first assist to collimate. When we do certain procedures that we're moving a lot, we'll actually enable our first assist to move the table and collimate so that our hands are not in the field. Takes only a few seconds. If you get into a good habit of it, you're really going to buy yourself a lot of radiation savings. This is one of the things that decreases radiation not just to yourself, but also to the patient, so it's a win-win situation. And sometimes it can increase conspicuity and actually make it easier for you to see. One example of this would be, I think we were doing a port here, and we did not collimate initially, and you can see that this is almost basically a chest x-ray. I mean, you can see from the patient's lateral ribs on the right to the mid-chest on the left. But all we really need to see is that wire. So then they collimated, and now all you see is about 10 centimeters in the middle of the chest, and we can actually even see the wire just a little bit better. And that has decreased the radiation to that patient's chest as well as forward scatter to yourself. So now we've used last image hold. Maybe we're wiring out and getting a new catheter, and we just need to know, oh, that's where it was, yes. And, you can do this versus DSA, but DSA is a much higher radiation exposure option. Now we're going to go to minimizing air gap. This is an extremely important habit to start very early. The reason being is it's another step that can protect both you and the patient, and it's a big source of significant scatter. So what we're seeing in these two pictures is where the patient's belly is and where the bottom of the eye is a large gap of air. Now, the yellow area almost 50%, which is a huge dose saving. These are much better examples of the air gap. This is a very acceptable air gap. We can basically see that there's variable air in between the patient's belly and the bottom of the eye. As long as this patient is comfortable, you don't want to close the air gap so much that the patient can actually feel the machine and feeling like they're being smushed in the machine. You don't want to do that. But they want to be able to breathe easily and not really feel like they can touch it. That's just where you want to be. So again, we're going to show on the left, that's what you don't want to do. On the right, that's what you want to achieve. Now, the reason this is important, we're going to go back to our procedure here. I think we were doing a port. Now, we see that there's a big air gap, and what they did is they raised the II because they needed to work on the patient's chest. So you can see that the doctor's eyes are down in the chest. His foot is not on the pedal. He's not looking at the monitor. He's not doing anything with Fluoro right now. So the nurse has wisely come around and checked on the patient during this time because she knows that Fluoro is not being enabled. So the doctor is going to finish what he's doing. He looks like he's cutting the catheter, measuring, and finishing up. So once he finishes up and he needs Fluoro, the patient's going to go back underneath the II, and that air gap's going to come down. The next thing we need to learn about limiting is magnification mode. Magnification is the thing that makes your life easy, but also increases your radiation. I think it's one of the highest risks during a procedure. This picture here is not a great one. It's just a coronary angiogram, but it gives you a picture that, it decreases the field of view so that everything's bigger, and it actually shows a smaller area. So if you take a 48 centimeter field of view to a 15 centimeter field of view, you're going to, increase your dose by a factor of 10. So one thing I've learned, because we watch exposure rates actively during the procedure, is that I think MAG is one of the things that adds one of the biggest factors in your exposure rates, and I try to limit it as much as possible, especially now that we're so aware of exposure rates. The next thing you can also do is frame rate. Again, this is something when you decrease the frame rate, you're decreasing your visual prettiness. You're going to decrease the visual resolution. But just as long as you're doing enough that you can get the procedure done safely. So you can use slower frame rates for simpler procedures, and you can diminish your frame rates to 7 or 6 or somewhere in there, and then you can employ your higher frame rates for your more complex procedures. Because for you, at the end of the day and at the end of your career, it's a combination of, okay, I had to use the higher settings for my complex procedures, but I did a lot of dose savings throughout all of my smaller and easier procedures because I really didn't need a lot of Fluoro. And the SIR workbook from SIR 2013 is a great reference. It's just 2 or 3 pages. It's a great reference if you guys want to refer to this. And it also talks about pediatric, some pediatric techniques, as well as some of the PQRI stuff that you'll have to do during your career. Pulse fluoro is very similar. Basically, you're just decreasing the pulse fluoro settings, your frame rate, and your pulses per second. If one example with that, if you decrease it from continuous to 7.5 pulses per second, then you get almost a 70% of dose savings. So I think that's worth your time to try and just see how that works for you. Now, once you get into your practice, and even in your fellowship, you'll come across multiple different kinds of vendors. Most institutions may favor one vendor, but some will have multiple. We have Siemens, Philips, and GE at our institution, so you really need to get to know your machine and get your staff to get to know your machine so that every machine has adjustments. And the vendor literature, although the vendors are going to want to set up your machine so that everything's very pretty, just make sure that you know that there are going to be adjustable rates, both for frame rate settings and exposure settings. For example, in our GE settings, we went from the aorta setting, from the aorta IQ setting, and I'll show you an example of that, and it has shown us significant dose savings. Philips has a very similar thing with Fluoro flavor. This is an example on our GE machine. On the left is the Fluoro dose rate that GE calls aorta, and then on the right, the aorta IQ rate control was employed. Well, obviously, the right is a much prettier picture, and you don't have to squint that hard to say where the catheter tip is on both. And you can see the port, you see that it's not kinked where it goes into the IJ, and you can see where the catheter tip is on both. There was a significant amount of exposure difference between these two pictures. So further, you're going to reduce dose to patient. We've been talking mostly about reducing dose to yourself, but there's a couple of things you can do to decrease dose to the patient, and we're going to talk about things that are inversely related as well. So if possible, you're going to change the view angle during longer cases, and you want to avoid overlap. So what you're thinking about is where the radiation source hits the skin. We're just trying to change where the source is hitting the skin. And that's what got the patient in the beginning of our talk a radiation skin burn, because the skin injury site was the same the entire case. I mean, you can see a perfect square on that patient. So using this technique limits the maximum dose to any particular skin location. It kind of, spreads the dose throughout the skin area. Again, you want to reduce your use of MAG because MAG hurts both you and the patient. Collimate, that helps both you and the patient. Decrease your frame rates and decrease your dose rate control. Now, sometimes you don't even think about it, but if there's alternatives, ultrasound, MR, other technologies, if a procedure can be done with ultrasound, then by all means, do it. I've actually become very in favor of ultrasound for ultrasound-guided liver ablations. We use microwave ablations for a lot of our HCC patients. And I think when I first started in practice, I did almost 100% with CT, and now I would say probably 80% I'm doing with ultrasound. It's much quicker, and it's much more accurate. So, if you're doing a cholecystostomy tube, really, that very little of the procedure needs to be done with X-ray. So if you can use ultrasound or MR guidance or other technologies, then by all means, pursue those avenues. Now let's talk about pregnant patients or potentially pregnant patients just for a moment. You need to be very aware because it's very easy to fall through. The nurse may not realize, the referring physicians, the pre-op nurses may not even think about this. But you're going to be exposing a patient to angiography. If you have a premenopausal female that by any shape, form, or fashion that can be pregnant, you need to consider her pregnant until otherwise proven. We do a urine pregnancy check for every patient that comes through our lab. That's part of our standing orders. And I've even started considering it as part of the timeout. We do it for our CT cases, and I'm considering doing it as a part of the timeout for our fluoro cases. The reason being is the risk of radiation during the prenatal period is unclear. I mean, we know there's some harm, we don't know how much, but in the first trimester especially, you should expect just to try to not expose that patient to any radiation unless absolutely paramount. If you have to think about it, we have patients that needed a splenic embolization the other day that had a childhood tumor removed and would have been a very difficult splenectomy. They wanted us to do a prophylactic embolization from trauma surgery, and we really had to talk about it with the patient and really have a heart-to-heart, and she was completely stable, and her hemoglobin was stable, so we opted not to do it because we really couldn't tell her that it would be a safe procedure. Now, if she had decompensated and it was necessary, then what you would do is try to collimate as much as possible to stay away from the conceptus and avoid any direct irradiation of the pelvis. You know, if you're doing something in the upper abdomen, like a liver or a splenic embolization, or something in the chest, it's not much of a problem. But if you have a pelvic bleed, like a pelvic ring fracture, you know, this is going to be a very difficult conversation to have, but you have to have it. You don't want to be having this conversation retrospectively.
Dr. Conner, are you still there?
I don't know what happened.
It looks like she.
Looks like her phone dropped.
Yeah, I see that too. Natasha, are you able to text her or call her and see what happened?
Yeah, I'm texting her right now.
All right.
Hopefully we'll hear back from her shortly.
Oh,
Okay,
looks like
are you
she's
guys
back.
still there?
Oh,
Yep, we're here.
Yep.
Oh, great. Okay.
I'm sorry, I'm not sure, it just dropped completely. Sorry about that, guys. So, did you hear me talking about pregnant patients?
Yes.
Yeah, I think
All
that's
right, I'm gonna
kind
go-
of where we
Okay,
lost.
I'm going to go to the next slide. Okay. Increase your radiation exposure for both you and the patient. However, there are a few things that are inversely related. So you're being very careful to decrease the exposure to the patient, especially in skin exposures where you're worried about skin injury, that these can absolutely increase your exposure to you. So that's where you really need to employ very heavily some of your shielding and things that we talked about at the beginning of the talk. Two things that you have to know about are your source to skin distance. So we're talking about decreasing the patient exposure because we're taking the patient's skin away from the source, which is essentially raising the patient's table upwards. What that does is it actually introduces a great bit of air underneath the patient, underneath the table, and away from the radiation source. So that's going to introduce forward scatter from the source to you below the table, and I call that a reverse air gap. There's not much you can do about that except for try to balance the amount of scatter that you're receiving with leg shields, and then also with all of your other shields, including your own personal lead. Dose spreading, in general, it's not a problem if you're staying in frontal plane, but if you start using various obliquities, what you can do is actually bring the radiation source closer to your legs, or even contralaterally, it's going to be pointing at you. So the photons are actually going to be closer to coming at you if you oblique away from you. So just keep that in mind, that if you can step away just a little bit, or make sure that you have your leg shield there, because sometimes if you're going quite in a deep oblique, you may not be able to use that leg shield, and you may have to work around it to try to get you to have some sort of barrier protection. So again, employ those aprons, employ the mobile shields, and try to decrease your time and increase your distance.
Dr. Conner, do you mind going back to the slide about pregnancy and just covering that? I think we kind of lost you midway through that slide.
Okay. Yeah, of course. Okay, so on radiation exposure for pregnant patients, essentially you need to check and make sure that the patient could be pregnant, and if she possibly could be, you absolutely need to do a pregnancy check. We do that for all of our patients. We actually consider it part of a timeout. The risk of radiation that needs to be discussed with the patient, because the prenatal period, we're really not sure how much injury can occur. We know that some can occur, particularly in the first trimester, but if it's a procedure that can wait, by all means wait. But if it's something that's emergent and you really need to do a procedure with the conceptus still in place, then you need to measure the risks and benefits, and you need to talk about this directly to the patient and make them understand that this is certainly a risk, and we have to measure the risk of not doing this procedure with the risk of radiation injury to the conceptus. Now, if it is necessary, if it's an urgent or emergent procedure, then the two things that are the best things to remember, one is to collimate as much as possible and to avoid direct irradiation to the pelvis. If it's a trauma patient and you're having to work in the pelvis, then you need to be really careful and have a great conversation with the patient and make sure that they're aware. And especially in trauma situations or emergent situations, you need to talk to the family, talk to the husband, talk to the boyfriend, because if that patient is unstable and you have that conversation to them and they say, you know what, let's do it, and then something bad happens to the baby later on, you know, even just from hypotension or whatever, and you didn't talk to the family, that's a place you don't want to be. So make sure that if the patient's unstable or if it's an urgent or emergent case, you need to be talking to the family, and that's just as paramount, if not more important, than talking to the patient. And I will even in my dictations, if there's something like this, I will say the consent was obtained from the patient in the presence of their family, with all family and patient and family members agreeing to the necessity of procedure. So then we went back to, you know, some of the inverse relationships you have for source to skin distance and dose spreading. Dose measurements, one thing I want to hit on is that fluoro time, although it was the standard dose metric for many, many years, and I still have it beat into my head that 60 minutes of fluoro is safe, it's not, because it does not reflect the effects of fluoro dose rate or dose from DSA. In addition, it's a poor indicator of dose and severely underestimates your risk to patients. Fluoro time measurements are not generally recommended now unless no other metric is available. And all the older machines may only still have fluoro time, but if you note, after 2006, it became an FDA requirement for any kind of angiography or fluoro units to have a dose measurement capability. If you have questions about this, ours uses cumulative air coma measured in gray, but yours may measure DAP, and dose area product. So if you have questions about what's a safe limit, or if your institution has questions about what a safe limit is, then you should probably consult your radiation physicist or your radiation safety officer for help. Again, fluoro time doesn't have a correlation or a linear relationship with measured exposure. For example, you can have a 20-minute procedure, a fluoro time 20 minutes, with a thin patient, good technique. It's an easy procedure, it just happened to take 20 minutes. You could easily have less than 100 milligray. However, you can take the same exact procedure and have the same amount of fluoro time. An obese patient, poor complex technique, is just a hard case, and you can easily take that 100 or less milligray, and it can be in the same patient, same procedure with these other variables, and it can easily be, you know, 50 or 100 times more exposure. And I've learned that quite a bit just watching these over the last 2 or 3 years. So with body habitus, the patient entrance exposure rate, meaning once it hits the skin and the time it leaves the body, if the patient is 20 centimeters in thickness, let's say AP chest thickness or AP body thickness, versus someone who's 10 centimeters greater in width, you can increase your factor by 2 or more. Just that, you know, just that 10 centimeters, and that's not a lot of space. I mean, it really doesn't take a whole lot bigger patient to have 5 or 10 centimeter greater girth. Oblique angles also increase this dose rate, because if you're going through an obliquity, you actually have more tissue to go through generally, and you're increasing that measurement from 20 to 30 or 30 to 40. So 2006 was a significant year with radiation exposure. The Joint Commission defined a Sentinel event. You know, at this point, if we go back a couple of slides, we say all machines now measure cumulative dose. Like fluoro time has gone away. We still measure fluoro time, it's still available, but we need to know what a cumulative dose is. So the Joint Commission defined the Sentinel event as a prolonged fluoroscopy dose at 15 gray to a single field. That's a significant time, a significant radiation exposure, and we have actually used that at our institution as a Sentinel event, but we also give a warning event at 5 gray. So, you know, prolonged fluoroscopy dose at 15 gray, if you're doing 15 gray, you need to see what's going on and see how important it really is to pursue that procedure. It really should be an emergency. Now, you have to have the mechanism to be aware. So if your machine was made 2006 or after, it should be there. And like I said, our techs will tell us, you know, once we get past 5 gray and 2 to 2.5 gray and so on, they let us know ever so often at the 100 milligray mark. And additionally, you think about what your medical follow-up and what kind of protocol do you want for a follow-up. If you're going to be doing complex interventional, then you need to have at least some sort of game plan as to how and when you're going to monitor patients that have very high exposure procedures. Why is this important? Let's go back to why this is important. If this ever happens to you on the left, it's very hard to take that back. And if you warn the patient and you say, we're going to watch you, we're going to do wound care and all these things, you have a much better chance of continuing your patient relationship with that patient versus, you know, the opposite end of the spectrum, which is obvious. This had to end in a litigation because this is a terrible burn. And it's on the same end of the spectrum, you also don't want to be suffering health risks at the end of your career when you should be retiring. And again, one good difficult tip is almost 3,000 chest x-rays. So we're going to go back to our single setting exposure deterministic chart. And I'm going to go through kind of what I do if I have a high exposure case. If you look at the 2 and 3 or 4 gray, you're talking about appellation at 14 to 21 days. You're pretty much in the clear. But if you notice, if you go down this chart, everything says 14 to 21 days or 7 to 14. So if you know that you did a case that had, let's say, 12 or 13 gray, and you know that it was almost in the same place, you know, you didn't move the II a lot, then you need to think about when you're going to bring the patient back. And if you look at this chart, you know, if you bring the patient back 2 days after the procedure, you're not going to see any erythema. You need to bring that patient back about 2 to 3 weeks, maybe even 4. Maybe you know, if you see any erythema, you should probably bring them back another week and consider wound care. So, you know, don't bring them back too soon, but you want to bring them back soon enough, 2 to 3 weeks, that you continue to establish that rapport, because what you would hate to see in about 6 weeks or 8 weeks is that the patient's already blistered and had an ulcer. And at that point, you know, the patient's already been dealing with it for quite some time. And maintain open channels with your patients and maintain honesty. If you had an emergent case and you saved their life, then they need to understand that, you know, a skin area of reddening is going to be the price that they had to pay. Versus if it's an elective case and you had a high exposure rate, then you really have to be honest with the patient that this is something that possibly could happen. And this is a conversation in an elective patient that needs to happen well before you're in the lab with the patient. So if you exceed your substantial dose, whatever you decide is a substantial dose, you know, timing, we're talking 2 to 3 to 4 weeks, discuss with the patient, and especially if it's an elective case and you anticipate it to be a complex case, consider putting that discussion into the consent. If it's life-saving, you know, you've still got to talk about the risk versus benefit, and we've actually considered putting it in our consent page that actually signs. And, you know, consider putting it into consent discussions for any patient that's going to be a moderately or complex procedure, especially if they're morbidly obese or if they have extremely difficult anatomy. So I would like to stop and take questions here and just see if anyone has anything they'd like to cover or have questions that applies to radiation safety.
All right, if anyone has any questions, feel free to ask them in the questions box or type them into the chat box, and we will be happy to ask Dr. Conner those now. We'll just give you a few seconds to ask anything if you've got anything, and Natasha will be fielding those.
All right, so let's see. Well, so one of the questions is, being in the IR suite daily, have you or any of your colleagues ever come close to the annual occupational limits?
I did about 6 months ago. And I will say that, you know, the radiation safety officer came and said, what did you do this last month? Because my numbers were actually way over than they normally were. And I actually wear and I didn't talk about it because it didn't dawn on me, but I actually wear a ring badge as well on my hand. And I actually went to GI and helped them do a rendezvous procedure where I had no control over the pedal or where the procedure was or the machine, and my exposure limits were way over what they normally are. So I learned that maybe I should do rendezvous in the IR lab and have GI come to me. But it doesn't happen very often, but they certainly, you know, our neuro guys, and when we are doing a lot of tips, we come close, and our radiation safety people are very good at letting us know.
When they come and tell you that, hey, you're getting close, is there a way you alter your schedule to, you know, so like maybe if you have another couple weeks, you're doing less big cases like that and you're passing them off to your partners, or what do you do to adjust to this?
So the idea is that you don't have to get to that point, and that's why they give you monthly badges, and we change out our badges every month. And so a good radiation safety department is going to be monitoring those every month. And what they do is they look at what you have for that month. Let's say it's your month 1, and if your month 1 projects you to be by month 10 over the limit, then they will come and notify you and say, hey, you're not going to make it to the end of the year. And if that happens, they get, I mean, you know, that's their job. They're not going to let you go over. So what they do is they go over your technique, and then they say, you know, well, okay, you should probably do this better. I see that the, you know, your shields don't have you have a bunch of dust on them. It looks like you're not using your shields. Or, you know, I see that, you know, you're doing, you know, your high exposure settings for every case. You know, they're going to question you and pepper you with questions about what can you do to decrease your technique. Now, if you've done everything right and it just so happens that you're doing extremely complex cases on a regular basis, then that's, you know, that's something that you're going to have to really have an honest conversation with yourself, because, I mean, in residency, I had attendings that would just take their radiation badges off their lead. And that's not the right resolution to that question. You just, you know, if these limits are here for your safety, and if you're doing such cases that, you know, you're going to go over that at month 10 or 11, then maybe you should decrease your workload, or maybe you should kind of get your partners to help, or maybe you should try ultrasound more. That's kind of why I kind of went down the ultrasound path, is when I started seeing that some of my averages were a little bit higher than I would like, but I never reached anywhere close to being out of the lab.
Okay. The next question is there an increased lifetime risk of cancers for interventional radiologists?
So there's really nothing that shows that. But, you know, we all have anecdotal friends that have had lymphoma or leukemia or cataracts or different things, but there's nothing that really shows that definitively. Part of that is because the techniques that we have now are so good. And, you know, if you look back 20 years ago, these guys weren't using any of the things I've talked about tonight. And the cardiology literature and the neuro-IR literature, including neurosurgeons and neurologists and all of these other people that are also using interventional techniques, there's really nobody talking about, okay, we have a definite link to this or a definite link to that. But I think you should still take precautions just in case, because if you have a familial or a genetic predisposition to cataracts, then this much more radiation may be something that caused you to have that problem.
Okay. Next question is, for estimating radiation dose in a case, what data source do you use? Your own institutional data for a type of case, or a published source?
Well, tell me the first of the question.
For estimating radiation dose in a case, what data source do you use? Do you use OU's institutional data, or a published source like a nationwide generalized source?
So we actively monitor every case, and actively monitor every case by physician and by type of case. And we used to, and we still do, monitor what the machine shows you at the end of the case. But we've also employed what we call Dose Watch, which was bought for our institution, and it's actually supposed to be more sensitive. And we've only just started using that, and I don't know how much more sensitive that's going to be yet. But we're using our own machines, and our radiation safety committee has set our own limits.
I think the last question is, logistically, can you really use all 4 shields for abdominal interventions, and do you?
Well, I would say in my lab that I'm probably the only one that takes the time to really pull them all out to the yawns and frustrations of my techs, because I do try. There are cases where it gets tossed out of the way. I would say for most angio procedures where we're at the femoral artery, a lot of us do use all of the three, the hanging shield, the bridge shield, and the leg shield. The fourth one was there for, if you have an assist that's really not doing anything. They're just kind of watching. But if you're doing something that's an abdominal procedure, like a PTC, a cholecystostomy tube, a left lobe biliary drain, it's very difficult to use the hanging shield. I mean, you might want to step back when you're doing a DSA run and kind of put it in front of you, but it's very difficult to use the hanging shield for things that your hands are very close to the abdomen. So, for those cases, you just do the best you can and just make sure that your leg shield is there, because that shouldn't bother you.
Perfect. I think that's all the questions we have today,
Okay.
Dr. Conner.
Okay, perfect.
If you want to go ahead
to
and move to your next.
Yeah, I'm going to go to some final thoughts, because since you guys are residents and fellows, this is the perfect time to start your good habits now, because once you've been in practice a couple of years, you're not going to do these things, or you're just going to kind of do what you've been doing. So please just remember your staff, and remember the poor nurse that's underneath the drape with the patient and scratching the nose, because it took me a long time to realize that I was fluoroing my nurse without realizing it. Find your radiation selectivity officer and find your physicist and make friends of them. They can make these things much easier for you. And then consider consent, especially for complex procedures. Consider having that discussion and just putting it as part of the informed consent. And most importantly, if you are doing complex procedures, have some sort of a follow-up plan so that you can say, I documented that I saw the patient, and yes, there was some erythema, but you know what, I knew about it, I informed the patient about it, and we're trying to fix it together. So good luck to you guys. Thanks for coming in tonight, and I'm sorry about dropping the call, but good luck to you guys in your careers, and please let us know if you have any further questions or anything in follow-up. You can always contact us.
Okay, so looks like there's one last question, and that question is about whether or not fluoro times or air kerma products are reported.
Are they reported to like an institute, like something outside the institution? Right now it's more self-reporting. I mean, you're not under any requirements to report your exposures at this time. If you do, however, exceed or have a sentinel event, they are to report that just as any event. Like if you're sedating a patient and you have to reverse them, that's an event that gets reported. So really, you should be aware of your institutional sentinel events, because that's the thing that will get reported.
Dr. Conner, I think the question was more in regards to individual dose estimation on individual cases and whether you guys report those on your dictations.
I do, actually. Yeah, we actually all do now. It's easy. It goes on the tech sheet, and we follow the fluoro time and the air kerma. And the reason I think we do that is a lot of these patients will come back and have multiple procedures. So it's always good, if you're worried about that it's in the medical record and it's easy to pull up.
Great, thank you.
All right, well, if there's nothing else, we're going to end for tonight. Again, thank you, Dr. Conner, for showing up. Thank you, Natasha, for leading that discussion. And again, Natasha is part of the Women in SIR group. So if any of you are interested in that group, you can get in touch with her to become a part of that. And just keep a lookout in your email for our next webinar. And this webinar will be uploaded to YouTube shortly. And then thank you all again for showing up.
Thanks, Fareed.
Thanks for a great talk, Dr. Conner.
Thank you, guys.